Welcome back, Dr. F here. Today we're going to be talking about Chapter 10 in our Neuroscience Fundamentals for Rehabilitation by Lori Lundy-Ekman, 6th edition. Today we're going to work through Chapter 10, the Peripheral Somatosensory System. So let's start with the big picture. What is somatosensation and why does it matter? Somatosensation helps us do three major things. We can investigate our world, make accurate movements, and avoid or minimize injuries. And when we say somatosensation, we're talking about sensory information coming from two main sources. First, we have the skin, that's cutaneous information like touch, nociception, and temperature. And then we have musculoskeletal system, which include proprioception and nociception. Now, one helpful organizing idea, the pathways that carry somatosensory information to the cortex are three neuron pathways: a first-order neuron, then a second-order neuron, and then a third-order neuron. The first-order neuron brings information from our sensory receptors into the spinal cord. The second-order neuron carries it from the spinal cord or the brainstem to the thalamus. And the third-order neuron carries it from the thalamus to the cerebral cortex. So, how does this first step happen peripherally? Peripheral somatosensation conveys information from the skin and musculoskeletal system into the spinal cord. And here's the sequence. First, peripheral receptors encode the stimulation into receptor potentials. If that receptor potential exceeds threshold at the trigger zone, an action potential is generated into the peripheral axon. Then that action potential will travel along the axon, past the T junction that leads to the soma in the dorsal root ganglion, and then continue along the proximal axon into the spinal cord. Once in the spinal cord, somatosensory information ascends in the white matter up to the brain. This is emphasized more in Chapter 11. One interesting detail about all of this, sometimes the action potential enters the axon stem at the T junction and invades the cell soma. When that happens, it can change gene expression in the soma and may also regulate propagation of action potentials to the spinal cord. Now let's zoom in on one key category of musculoskeletal sensation called proprioception. So proprioception, or what your body knows without using vision. Proprioception is the information about the relative position of your body parts in space without visual confirmation, so without the use of your eyes to see where your body is at. It is based on input about the stretch of muscles and skin, tension on tendons, the position of joints, and deep vibration. It can include both static joint position sense and kinesthetic sense or movement sense. And with that in mind, let's talk about the receptors that make this possible. Sensory receptors are located at the distal ends of sensory peripheral neurons. They can be specialized end organs or free nerve endings. They contain ion channels that are sensitive to different environmental stimuli. You have your mechanoreceptors that respond to mechanical deformation like touch, pressure, stretch, or vibration. Our chemoreceptors respond to exogenous chemicals or substances that are released by cells. These include substances released by damaged cells after injury or infection. And you have your thermoreceptors, which respond to heat or cooling. Chemoreceptors and thermoreceptors are associated with free nerve endings. Mechanoreceptors can use either free nerve endings or specialized end organs. Now, let's split touch into two clinically useful categories. Light touch is tactile information that lets you specifically localize where on the skin stimulus is occurring. It is conveyed by end organs and is also called discriminative touch. Crude touch, on the other hand, is a tactile information that does not specify a location, and it's conveyed by free nerve endings. You'll often see classic end organs listed here, like Pacinian corpuscles, Ruffini corpuscles, Meissner's corpuscles, Merkel cells, hair follicle nerve endings, along with free nerve endings. Now, let's talk about how receptors respond over time. You have your tonic receptors and your phasic receptors. Tonic receptors fire the entire time a stimulus is present, while phasic receptors adapt to a constant stimulus and stop responding even while the stimulus is still present. And they're especially useful because they alert the body about the change in a stimulus. And now that we've got the receptor basics, let's follow the signal into the nervous system by focusing on first-order neurons. Somatosensory first-order neuron cell bodies, or somas, are located outside the spinal cord in the dorsal root ganglia. They're pseudo-unipolar and have two axons. The distal axon conducts messages from the receptor to the T-junction, and the proximal axon conducts messages from the T-junction to the spinal cord. They're also called primary afferents. Now that we classified these afferents partly by diameter, and diameter matters a lot because it's going to link to how fast this moves. Somatosensory first-order neurons are classified by axon diameter and whether they innervate musculoskeletal or cutaneous structures. For musculoskeletal primary afferents, in order of declining diameter, so 1A being the biggest and 4 being the smallest, you have 1A, 1B, 2, 3, and 4. For cutaneous primary afferents, in order of declining diameter, our biggest is going to be alpha beta, then alpha delta, and then C fibers. And the big rule, the larger the diameter, axons transmit information faster than smaller diameter afferents. Also, action potentials in most large diameter primary afferents are triggered by mechanical stimuli. A quick way to anchor this is 1A fibers are among the fastest, while C fibers are among the slowest. And this sets us up nicely to talk about polymodal afferents and nociception. So for polymodal afferents and nociception, most medium and small diameter primary afferents, like 3, 4, alpha delta, and C fibers, are polymodal, meaning they transmit signals from multiple modalities, including mechanical, thermal, and chemical stimuli. Many polymodal neurons are nociceptors. When we talk about nociception, a key idea is that nociceptor activity changes significantly after tissue injury. In healthy tissue, silent nociceptors are relatively insensitive, but after tissue damage, they can become spontaneously active and respond to mechanical stimuli. After injury, peripheral sensitization also occurs, meaning nociceptors fire more action potentials in response to a stimulus than they would under normal conditions. Together, these factors increase nociceptive messages into the central nervous system. So now we can shift from pain into something that you'll actually test clinically all the time. Let's look at cutaneous innervation and two-point discrimination. So receptor fields tend to be smaller. The fields themselves are smaller in distal skin and larger in proximal skin. Also, distal regions of the body have a greater density of receptors than proximal areas. Let's break this down in a practical way. The combination of smaller receptor fields and greater receptor density distally allows us to distinguish between two closely applied stimuli on your fingertip, a distal portion of your skin. If you use those two closely distant stimuli, spaced the same distance apart on your trunk, you would not be able to feel them as two separate points. That's exactly what a two-point discrimination test is capturing clinically. Now, as we think about testing sensation, it is worth remembering that not everything we sense becomes conscious. So we have conscious versus non-conscious somatosensation. Only a small portion of primary afferent information actually reaches conscious awareness, and that prevents sensory overload. Most information from primary afferents is used to make autonomic adjustments, and it's selectively prevented from reaching consciousness through descending inhibition and local inhibition. Now we're going to pivot to a classical clinic pattern recognition skills, which is dermatomes versus peripheral nerve distribution. Peripheral nerves connect motor and sensory end organs with the central nervous system. Dermatomes are used to diagnose radiculopathy, which is an inflammation or compression around a nerve root or a pinched nerve, and can determine the sensory level affected by spinal cord injury. So here's a key distinction. For the trunk, spinal dorsal roots are continuous with peripheral nerves, so there's no difference between dermatomes and peripheral innervation. For limbs, there are two distinct distributions, your peripheral nerve pattern and dermatome patterns. Practically, this can be a diagnosis shortcut. A dermatomal sensory change can suggest a nerve root issue like radiculopathy. A peripheral nerve sensory change can suggest a lesion or entrapment of a specific nerve. And now that we've laid the groundwork, we're going to move a little bit deeper, literally, into our musculoskeletal innervation and proprioceptors. Musculoskeletal innervation includes fiber types 1 through 4. Axons that carry musculoskeletal sensory signals are classified with Roman numerals 1, 2, 3, and 4. You have your larger afferents, which are types 1 and 2, that carry information about muscle stretch and tendon stretch. And then you have your smaller afferents, which are types 3 and 4, which carry our nociceptive information. And this brings us straight into one of the most important proprioceptors, our muscle spindle. The muscle spindle is a sensory organ that's embedded in each skeletal muscle. It consists of muscle fibers, sensory endings, and motor endings. The sensory endings will respond to stretch, both changes in muscle length and velocity of that change, how it changes, how quickly it changes. And for spindle to detect stretch, the central region of the spindle muscle fiber has to be taut. So now let's talk about the intrafusal fibers inside of the spindle. Intrafusal fibers exist to provide sensation, not to generate external force. They're contractile only at the ends. The central region cannot contract. The ends connect to connective tissue surrounding extrafusal fibers, so when the muscle stretches, the intrafusal fibers stretch too. And there are two types of intrafusal fibers. You have your nuclear bag fibers, which are clumps of nuclei, and your nuclear chain fibers with nuclei that are arranged in a single file. Now we're ready for how the spindle actually signals what's happening. Primary endings from type 1A neurons will wrap around the central region of each intrafusal fiber. These will act like phasic receptors, where their firing is maximal during quick stretch of the muscle. Secondary endings from type 2 afferents and mainly on nuclear chain fibers adjacent to the primary endings. These behave like tonic receptors. Their firing is proportional to the amount of stretch placed on the muscle. So if you want a quick summary over what this all means, 1A is tuned into change in speed, while type 2 is tuned into ongoing stretch. But here's the next problem. If the muscle changes length a lot, how does the spindle stay sensitive across the whole range? That's where spindle efferents will come in. Our spindle efferents are keeping the spindle responsive to sensory information. So spindle efferents maintain the sensitivity of the spindle throughout the normal range of muscle lengths. Gamma efferent control is dual. We have gamma dynamic axons that innervate the contractile ends of the nuclear bag fibers to adjust sensitivity to the velocity of muscle length changes. And gamma static axon innervates the contractile ends of the nuclear chain fibers and some nuclear bag fibers to tune sensitivity to static muscle stretch. All right, our next proprioceptor, instead of muscle stretch, we're going to focus on tendon stretch. So Golgi tendon organs, what stimulus are they detecting? Golgi tendon organs consist of encapsulated nerve endings woven among collagen strands of the tendon near the musculotendinous junction. Tension in tendons is relayed from Golgi tendon organs. They're sensitive to very slight changes in tension, and they respond to tension from both active contraction and passive stretch of the musculotendinous unit. Now, we'll extend that idea into another proprioceptive source, our joint receptors. Joint receptors respond to mechanical deformation of joint capsules and ligaments. The afferent associated with joint receptors include ligament receptors using type 1B afferents, Ruffini's and pisciform endings using type 2 afferents, and free nerve endings using type 3 and type 4 afferents. Now that we're going to transition into clinical application, let's see how these concepts will show up in real patient presentations. The first clinical application that we have is herpes zoster or shingles and post-therapeutic pain. Herpes zoster is an infection of the dorsal root ganglion or cranial nerve ganglion with varicella zoster virus. After one has chickenpox, latent components of the virus remains in somatosensory ganglia. If there's an inadequate level of circulating antibodies, the virus begins to multiply. Then the virus is transported in the anterograde direction along somatosensory axons to the skin, causing a painful rash with eruptions. It usually affects one or two adjacent unilateral dermatomes, often in the thoracic region or ophthalmic branch in the trigeminal nerve. In terms of impairments are going to be limited to somatosensation. The motor system is not impacted with shingles. If severe or inadequately treated cases, post-therapeutic neuralgia or severe nerve pain can develop. If varicella zoster is treated with antiviral drugs within 72 hours of rash onset, that reduces viral replication, the duration of the rash, neural damage, severity and duration of pain, and the duration and incidence of post-therapeutic neuralgia. And the zoster vaccine for people older than 50 prevents varicella zoster or diminishes its severity and duration. The next clinical category we'll talk about are peripheral nerve lesions. So now with peripheral nerve lesions, we have to think about why the axon diameter is clinically relevant for these. Neuropathy is the general term for dysfunction or pathology of one or more peripheral nerves. Lesions affecting peripheral nerves may cause gain of function or increased sensitivity like hypersensitivity and or spontaneous pain, or loss of function, so decreased or total loss of somatosensation in that area. Loss of function can be partial when a lesion interferes with nerve conduction. Examples include diabetes and repetitive trauma disorders, or completed when a peripheral nerve is completely severed. If a peripheral nerve is completely severed, you get lack of sensation in that nerve's distribution. Pain may still occur, and sensory changes are accompanied by motor and reflex loss. Here's one of the clearest clinical relevant statements. Sensory loss proceeds in order of descending axon diameter. First, conscious proprioception and light touch, then cold, then fast nociception, then heat, then slow nociception. Now, let's connect proprioception loss to coordination. This is where something called ataxia comes in. Ataxia is incoordination that is not due to weakness. There are three types of ataxia. sensory, vestibular, and cerebellar. A lesion can affect peripheral sensory nerves, dorsal roots, or central neurons that convey somatosensory information. The Romberg test is used clinically to distinguish between cerebellar ataxia and sensory ataxia. Now, one more clinical tool that ties directly back to axon diameter and conduction speed, sensory nerve conduction tests. Let's see what sensory nerve conduction tests measure. These studies evaluate the function of our peripheral nerves. Because large diameter axons normally conduct fastest, NCS testing in intact nerves measure only the performance of large diameter axons. Conduction velocity equals the distance between electrodes divided by the time from stimulus to the first depolarization at the recording electrode. To decide whether an NCS result is normal, 3 numeric values are compared either to the unaffected nerves in the same person or to published norms. Distal latency, or the time for the depolarization evoked by stimulus to reach the distal recording site, amplitude of the evoked potential, and conduction velocity. So to close, let's wrap up with a little bit of a summary. We have our light touch receptors that are located in the skin. Our proprioceptors are located in things like muscle spindles, joints, ligaments, and tendons. Our nociceptors are located in all types of tissues. And somatosensory information is used to explore the world for movement control and prevent or minimize injury. And that's it for Chapter 10, Peripheral Somatosensation, from receptors to first-order neurons to clinically relevant patterns and tests. Thank you all for tuning in. Bye.